Hi, I'm Amy Reyes. This week from Rheumatology Network, we highlight some of the work our writers have been producing on osteoporosis, osteoarthritis, and gout. Our writer Katie Robinson summarizes two reviews from Nature Reviews Rheumatology. In the first, researchers examined recently published studies on lupus nephritis, which they find is still understudied despite overwhelming negative outcomes for patients with lupus. And Katie also shares a review that shows while there are a number of genes associated with osteoarthritis, epigenetics can heighten the risk for men and women who are already genetically predisposed to osteoarthritis. Our writer, Ingrid Torgerson, features a series of new studies on osteoporosis. One from the journal Archives of Osteoporosis finds that high platelet counts are associated with the development of osteopenia and osteoporosis. And in a second study, this one from the Annals of the New York Academy of Sciences, she focuses on the risk of atrial fibrillation in patients who are taking bisphosphonates. Researchers reported that the evidence of a link between the two is conflicting. And finally, in today's video, we talked with Dr. Brian Lamoureux, a rheumatologist and a medical director of Horizon Therapeutics in Deerfield, Illinois. He is currently volunteering as a rheumatologist with Community Health, a free clinic in Chicago, where he has been caring for rheumatology patients who are at high risk of contracting COVID-19. In this interview, Dr. Lamoureux shares the story with us. Welcome, Dr. Lamoureux.
Okay, well, thanks for having me. I am Brian Lamoureux, a rheumatologist in the Chicagoland area and a medical director with Horizon Therapeutics.
Mm-hmm. And what is Horizon Therapeutics?
So a very patient-focused biotech company, really mostly centered on meeting unmet needs for patients, especially in the rheumatology, ophthalmology, or orphan disease space.
Mm-hmm. So this is a clinic in Chicago.
So Horizon is my kind of main day job, and I also volunteer at a clinic that is in downtown Chicago, and this is called Community Health.
Mm-hmm. Mm-hmm. I see. And how long have you been there?
Just about 2 years. Yeah, mm-hmm. So I tend to go, it was every 3 to 4 weeks when I started, but now I've built a nice patient panel, and so I'm going about every 2 to 3 weeks. Usually a Tuesday morning, I used to train down, but now I tend to drive down since traffic is reduced and concerns are raised.
Mm-hmm. Yeah. So you're doing double duty. You serve as a physician somewhere else as well?
Yes. This, seeing patients is very, very important to me. It was, the reason I got into medicine. And so when I was talking with Horizon originally, I kind of told them I would really, it's important to me to still see patients. And they said, absolutely, just take the time and set it up and we would fully support that. And they completely have. So, as part of my, weekly, activities, when it's a clinic week, I just kind of go down there and take care of my patients.
Mm-hmm, mm-hmm. Because there's been an unmet need in rheumatology for a while now. Some parts of the country don't have access to rheumatologists at all.
Yes, so that was actually a main part of this, is that this clinic is really a wonderful place. They have a very strong network of primary care physicians, but they don't have a lot of specialty access, rheumatology specific. So the clinic sees about 7,000 to 8,000 patients who are all by definition low income and uninsured. Many of them are going to be undocumented immigrants, primarily Spanish and Polish speaking. And so, when I reached out and connected with them, they leapt at the opportunity to bring in a rheumatology specialist. And so I've built a panel, probably 50 to 75 patients. It's tough to get an exact count, but I'm seeing a lot of rheumatoid arthritis, a fair amount of lupus, polymyalgia rheumatica, a little bit of gout, basically everything that you'd see in a regular rheumatology clinic, I have in my practice here.
Mm-hmm. And before you started driving down, what did these patients do for access to care?
So they had a rheumatologist who left just a little bit before I was gearing up. And so I was able to step in and take over the doctor's panel while building my own panel as well. So I don't think there was a huge gap. They do have 2 other rheumatologists that do stop by, but I don't think it's as frequently as I go.
Mm-hmm. Mm-hmm. And what are you finding in this patient population as compared to other populations you may have worked in over the years? Was there more of a need, maybe a lapse in care? Mhm.
Well, there's just a need for good medicine, right? These are patients that are by definition a bit vulnerable, and they may have some distrust of medical systems, and that's one of the things that community health really just strives to overcome and alleviate at every opportunity. So, some of them, in fact, most of them still have jobs, and we're in insured patients, when you have really, profound rheumatic diseases, it's a little less common. Maybe you work full time, but a lot of these patients do manage that quite well because they have to for their families. Um, and so some of their diseases have gone on for a while without the kind of intervention that you would like. And so, there's often some work up front to verify the diagnosis and, make sure the patient understands what's going to happen. And then you get them to the therapies that are going to help them to function and do better.
Mhm, mhm. And so they're working and they are probably in roles that might expose them to a possibility of COVID-19 infection. Are there those concerns as well? Mhm,
Sometimes. I have a number of patients that work as house cleaners,
mhm,
and they're not doing this quite as much. If the families are purely home, they don't go in. If the families leave every once in a while, then they will do some of this.
mhm,
Um, Other folks are in construction and other occupations, and
mhm.
I've not had a chance to check on a lot of these folks in the last couple of months. But for the most part, as far as I can tell, they're sheltering in place wherever possible.
Yeah, yeah, that's good. And what about access to medications? Do they have the medications they need? Are they facing any shortages?
Right. So all the medications community health provides are donations
Mhm,
from other companies, and they actually have a really quite a strong formulary of medicines, including a number of rheumatology specific medicines that I have access to. When patients need more therapy, like a biologic, such as a tumor necrosis alpha inhibitor for rheumatoid arthritis or psoriatic arthritis, we can often get that through compassionate use programs. And so we have pharmacy staff that will fill out the paperwork and help the patient to do what's necessary. And I find that they really are able to get access to these medicines when we need. Now, at this point, it almost feels like 2.5 months ago when hydroxychloroquine or Plaquenil was touted as a cure, an answer for COVID-19. The subsequent data has really shown quite the opposite, that no, this really doesn't seem to have much of an effect. We need to look elsewhere. But at the time, all of our Plaquenil, one of the medications we have on formulary, was donated. And so there was kind of a rash of doctors prescribing this for themselves and for their patients, and so that we were concerned it would run out. So I reviewed all of the charts of patients on this medicine, and I tried to reduce folks from twice a day to once a day. If someone could go off of it safely, I did that, and if folks needed it, we kept them on. So adjustments like that to respond to the climate, what's happening, and just being aware of that is a big part of this, because we want to make sure that our patients don't go without, so we maximize what we have at every chance.
mhm. Yeah, we were curious about how they were doing in terms of access to medication. So it's good to know that you guys are working even more overtime in order to get them the medications they need, finding resources for this. So I didn't know these resources were available. So that's good to know. Um,
Definitely.
yeah, and how are you doing? You've got two roles now, and with COVID-19, it's probably a little more stressful. But as a physician, how are you doing?
Oh, I've been stable. The hardest part is when all the various aspects of your life kind of just peel away or even disappear in a poof of smoke. I mean, I'm accustomed to traveling quite a bit for work, presenting, showing data, interacting with my peers and colleagues. When I'm here, I have my gym, basketball, usually 3 or 4 times a week. We have social engagements and dinners with friends. And so when all that disappears, you kind of have to adjust your time. And we find ourselves with a lot more time than we've previously had. But my wife and I both got tested for COVID last week, just voluntarily. We didn't have any symptoms, and we're both negative. So sheltering in place has been working. You might notice I moved my office to the second floor. I always just worked in the basement,
Right.
and after 8 weeks of that, it was too much. You can't spend 8 to 9 hours in a basement. It's just not natural. So I moved up to an ancillary bedroom, and now I've got a window. I can see stuff that happens, and it's a lot better. So I think it's about finding little coping techniques instead of basketball, I'll jog in the morning, do some exercises, calisthenics in the park a little bit. And unfortunately, we've canceled a number of family events. And I think everyone has. All the medical meetings that we're going to have been canceled through at least September. And so if you have family events that are occurring in, June or August, it's just not the right time. We have to kind of collectively keep each other safe by not doing stuff. So, it's all about just hanging tough here.
Right. And it's working. So, so that's good to know. Yeah. And in terms of your staff, how are they doing?
So the staff on site at the clinic have been dramatically reduced. By way of example, at the phlebotomist office for those COVID tests, there was no one in the office except the phlebotomist. So when it comes down to essential staff, it's the person who does the blood draw, and she took us back, one at a time. All the administrators are gone. There's no one else there. At Community Health, they've reduced it to just the most essential people, and everyone wears a mask all the time. The waiting room has mandatory spacers, and there's frankly very few patients there anyway. They now have drive-up or walk-up testing, so anybody that we're concerned about can just go to the back of the building and get COVID testing, we didn't have that just a few weeks ago, so it's a nice addition. It's all about just finding who can be at home and who needs to be there, and with the folks that are on site, how do we keep them as safe as possible? So a week or two ahead of my clinics, I will look and see which patients could be bumped to a later appointment, which ones need to be seen remotely, and which I really need in person. And the catch with the telemedicine part of it is, in this patient population at Community Health, they don't have video technology. So it's going to be phone only, and it's going to be through interpreter. So I call a Spanish or Polish or other interpreter, then we together call the patient. And so it's a bit tough. There are some detailed questions that I need, medication information. Patients usually just bring their bag of medicines, and that's out the window with telemedicine. So when you make that decision to go to remote, you have to kind of acknowledge what you're likely to be missing. And so if patients have things going on, if I'm really concerned about what or how much of medicine they've been taking, if I need a good physical exam, I will ask them to come in person. And if they otherwise are stable, their labs are good, I'll probably try to do one telemedicine, and the next time bring them in person. I think a lot of the other clinics, the universities, private practice, they're 100% virtual because everybody has video, and the patients can come in reliably and get their meds and get their labs. But we don't quite have that luxury, so we have to balance a little bit.
I see. And what is a typical example of a telemedicine visit?
Yeah, so with telemedicine, I find it's just good to go back to the basics. You want to start, just ask them in general how things are going, anything they want to talk about, and then we'll jump into the questions that I have. How are their medicines going? How is their disease doing? Kind of get the questions that I need. You try to infer a physical exam. You can hear from their voice whether they're nervous and anxious, but you ask them to identify any swollen joints, things that are painful when they walk, maybe even squeeze some of those joints. It's a lot easier when you do the video because they can just hold their hands up and you say, well, look at this one and squeeze it and tell me if that hurts. You can have them kind of test some of their range of motion and things like that. But by phone only, you don't have those opportunities. And so it's going to be limited. Hence not going too many visits in a row by phone only. Really want to get that in-person or video part of it. And then, you definitely need to leave time towards the end to explain very, very clearly, what's going on and what I want to do from here. If I need them in a week or two, or if I see they're coming in for a medication update or refill, I'll check labs then. And I'll tell them, hey, call in advance, call a week ahead and say, I'm going to be here Thursday at 11 to get my medicine. Can I also get a lab draw? Because that will minimize their time in the waiting room and, effectively use everybody's afternoon. So it's a little more planning and just leaving time to very, very clearly tell the patients exactly what I want to happen from here and make sure they agree and answer any questions they have.
Under normal circumstances, how often would, say, rheumatoid arthritis patients see a doctor?
If they're doing okay, every 3 months is quite reasonable. If they're not doing so well, you see them as often as they need, every other week, once a month. But in general, I've done quite well seeing my patients with RA every 2 to 4 months, depending on how stable they are.
That's good. And with some of your lupus patients, for example, who are taking a hydroxychloroquine and they scaled back a little, how well did they do during that period?
So they did okay. The day that I did those chart reviews, I actually was in clinic and I saw a patient on hydroxychloroquine 400 a day.
Mm-hmm.
And we had just actually tried to decrease her and she did worse. So she was one of the ones that I said, we got to keep her on 400. But in fact, some of the newer guidelines coming out with hydroxychloroquine actually recommend lower doses.
Mm-hmm.
And so this was just kind of a good time to talk to folks. Hey, this medicine might be running a little bit out, but actually we overall want you on a lower dose anyway. And so that kind of worked out
Right.
in general quite well.
Mm-hmm. Good. Yeah. Well, some good things, some learning opportunities, can come
Mm-hmm.
about out of something, very negative, so that's good. In terms of next steps, how do you see the next month or two going? Uh,
Right. So I don't know how much you follow the Chicago Tribune or Governor Pritzker in Illinois news, but we're not kind of seeing the downtrend we would have liked, especially in Lake County where I live and Cook County where I practice downtown. So, Illinois may start to reopen a bit in June, but these two counties, the most populated two, as far as I know, might get pushed out even more. So, that's one of those things that we're going to have to kind of face together. We hope that all this mandatory social distancing has done the job, and we're seeing things go in the right way. But the patients are aware of this, and sometimes when I ask them to come for medication refills, they say, "Well, I don't want to go outside. Is it safe to go outside?" And you kind of have to balance that anxiety with, you have an autoimmune disease, and I don't want to have you getting a flare because you have to go to the hospital. And that's just not a good idea. It's not safe for you right now. So, overall, just watching these trends, being aware of, the patients and their concerns and all that.
Yeah. So it's a wait and see. Yeah, and continue on. Okay. Well, thank you very much. I appreciate your time. And
Of course.
was there anything else you'd like to leave us with?
Well, no, I mean, the rheumatology community in general has adapted to this. Telemedicine has been embraced, and with the videos, you really can get most of what you need. The infusion centers are one thing that there's no substitute for in person. And so, doctors have been delaying less essential infusions, putting fewer patients in the room at once. Patients will wait in their cars until it's time to come directly for their infusion. They go right past the waiting room directly to their chair where they have social distance, they have a mask. Things like this. You do it virtually, safely, whenever possible, but for the things that have to happen in person, you find ways to do it where you minimize risk for everyone involved. And rheumatology has done this. I've been very impressed and pleased with my field and my colleagues in how we found ways to provide great care for our patients, even in these kind of trying, unusual times.
Okay. Well, thank you. Thank you very much.